Hi there, and good morning. It is my pleasure and honor to talk to you today for the next 30 minutes about olfaction in the era of COVID-19. My name is Carol Yan. I'm an assistant professor of rhinology and skull-base surgery at the University of California, San Diego. I have no relevant financial disclosures. So the goal of today's talk is to talk about the prevalence and significance of olfactory and gustatory dysfunction that's been associated with COVID-19. I know it's something that you've all heard a lot about, and we just wanted to go into a little bit more details and kind of review some of the literature that's been published recently. I'd like to also talk about the pathophysiology and the workup of olfactory dysfunction, as well as discuss the potential therapies that are out there and what we know about them in terms of its treatment for COVID-19 specific olfactory loss. So in terms of smell loss, what does it mean? What is the impacts? So as you may or may not know, smell loss and taste loss is associated with not only increased morbidity, but actually increased mortality. And it's believed to affect up to 1 in 5 adults by the time they've reached the geriatric age, and with increasing frequencies as we age. So the loss of smell is often accompanied by the loss of taste, which is really the flavor of the foods. So people can often taste the bitter, salty, sweet, sour tastes, but they can't really appreciate the flavor and the kind of pleasure of food in the everyday sense. So as you can expect, it has significant adverse impacts on the quality of life, leading to malnutrition, social withdrawal, and depression. And there's actually really poor self-recognition of olfactory impairment. So often people don't really realize they've lost their sense of smell until there is one scent that everyone else has noticed and they haven't. So smell loss itself is caused by many etiologies. Probably the most common, especially for otolaryngologists, is sinonasal inflammatory disease. That's your sinusitis, your rhinitis. And then we see this in sinonasal tumors and also iatrogenically after a skull base resection. So what we know is it's actually also caused by many viral infections. Parainfluenza is a big one, influenza, different coronaviruses. In fact, one study showed that it's been associated with over 200 viruses prior to SARS-CoV-2. Trauma or shearing of the nerves, neurodegenerative diseases can cause it, hereditary and genetic causes, and then toxins, medications, and of course, the just physiology of aging can cause smell loss as well. So let's talk about COVID-19 associated olfactory dysfunction. So it's pretty clear to pretty much everyone now that COVID-19 is strongly associated with smell loss. And this is just showing the number of publications on this topic. It's really been astounding. And I think this particular meta-analysis was published end of last year, and by the end of 2020 it shows that the number of publications which are depicted in these circles at the time is just remarkable. And we see, kind of based on this color scheme, that that the overall prevalence of the chemosensory loss is associated with COVID-19 is about roughly 50%. But there does seem to be an ethnic difference. So compared to Western countries, Asian countries reported a lower incidence of chemosensory loss associated with COVID-19. What is the impact of smell and taste loss associated with COVID-19? Well, these numbers are actually quite staggering. If you think about over 100 million people have been diagnosed with COVID-19 to date, and roughly 50% of them have smell loss. Studies have shown more recently that of those, about 20% have persistent smell loss, and that's defined as smell loss that's greater than 2 months of duration. That really leaves over 10 million people who now have new onset smell loss related to COVID-19, in addition to all the people who've had chemosensory dysfunction from other etiologies. So you can see, based on these numbers, kind of the immense interest now that the chemosensory field has to the lay person in the media and public, as well as providers such as ourselves. And that's kind of garnered a lot of research interests and a better understanding of the causes and treatments for smell loss. It's now been found through multiple studies that smell loss is one of the strongest predictors of COVID-19, even better than some of the more commonly used symptoms such as fever and cough. And these two articles highlight them nicely. So they were crowdsourced studies that surveyed the general public about their symptoms and their COVID-19 testing results and how they correlated. So the one on the left by many colleagues used about 13,000 COVID-19 positive patients, mostly in the UK and the US, that self-reported using this phone app called the COVID-19 Tracker app. And they found that the presence of smell or taste loss was had a higher specificity, positive and negative predicted value compared to symptoms of fever and cough for being COVID-19 positive. Similarly, Gerken and colleagues also used a crowdsourced questionnaire, and this was translated into impressively 23 different languages, and they assessed symptoms in individuals who self-reported recent respiratory illness symptoms, and they found that the change of smell and taste, or the loss of smell and taste, was most strongly associated with COVID-19 compared to all other clinical characteristics and symptoms. And similarly, this is a recent study published in JAM and Odo that I thought was unique because it really assessed the diagnostic value of smell loss prior to even knowing about your COVID-19 test results. So besides just the patient-reported symptoms of smell loss, these authors used a novel smell test, which they called the Clinical Olfactory Dysfunction Assessment, or CODA, and that relied on the identification and intensity scores of 3 scents. They used lavender, lemongrass, and mint. And really, the CODA score that was less than or greater than 3 was more likely to be associated with COVID-19 positivity, and as well as a self-reported smell and taste loss. So basically, in the COVID-19 group, at least 1/3 of patients had both smell, taste loss, and lower CODA scores compared to the COVID-19 negative group. So together, all three studies show that smell loss is truly one of the strongest predictors of COVID-19. Earlier on in the pandemic, our team at UC San Diego and others reported that the symptoms of smell loss were not as correlated with the SARS-CoV-2 PCR positivity. And these findings were really important for people wanting to return back to work after getting the virus, and to emphasize that they should not take into account persistent smell loss as an indication that they still have a viral burden and shedding potential. So this was actually corroborated by Cho and colleagues, who further found that the actual initial viral load did not correlate with your likelihood of getting smell loss. And they looked at the CT counts on a qPCR for the virus of SARS-CoV-2 and found that it really didn't correlate to the people who had higher PCR CT counts compared to lower in their likelihood of losing their sense of smell. In fact, our team has also found that patients with milder forms of COVID-19 may be more likely to lose their sense of smell and taste compared to those who are getting more ill, and that either reflects a lesser viral load or potentially a change in the immune system. So perhaps a million-dollar question is, what is this natural course of disease? Meaning, what can we do and what can we tell our patients who come to see us in clinic with smell loss related to COVID-19? And there are limited numbers of data and studies with truly objective, validated smell function data. One of these studies was published by Moen and colleagues looking at a cohort of patients in Iran. And this was a group of COVID-19 inpatients who underwent smell testing using the UPSET, or the University of Pennsylvania Smell Identification Test. And what they found is at test 1, which is fairly early on presentation, that's about 1 to 2 weeks after these people had symptoms, 96% of patients uh, initially had what's considered objective smell loss. So um, that was far more than the number of people who thought they had smell loss and actually self-reported at the time. However, at 7 to 8 weeks time point after the onset of symptoms, only 39% had persistent tested smell loss. So that actually is promising. That shows about 60% of people do recover by 7 to 8 weeks. And this data was followed up and actually shown with even higher numbers of recovery. And this is a recently updated prospective study from one of the largest cohorts of European patients. This looked at 1,363 patients followed for at least 60 days out. And they found that they looked at subjective self-reported smell loss versus objective testing using the sniff and sticks. And what they found was that subjectively, people reported that after over 2 months or 60 days, 25% of people still reported smell loss. When they objectively tested a cohort of those patients, of 233 patients, they found that actually only 15% of those people had objective smell loss. And so what that suggests is perhaps actually what we found as well is that people don't realize they've recovered their sense of smell, and they still might feel that their deficit of smell loss is greater than what actually is tested. And this study actually looked at a very smaller subset of patients who they had data on for even up to 6 months. And they've cited a 95% recovery rate, which is very promising. I think the numbers that they use are still a little bit small to quote this widely, but what we're seeing is that after 2 months, people are still recovering their sense of smell. And certainly with other viruses, we've seen that post-viral smell loss, you can get spontaneous recovery that lasts for 2 years after the onset of illness. So meaning if we tell our patients that even if they did nothing, that there is still a chance that, years from now, they might still get some recovery in their sense of smell. So I think I tell patients that when they're coming to me regarding COVID-19 related smell loss, because it does give them some hope, because the overall etiology of their smell loss from COVID-19 is still pretty early on and most of the time under a year. In this study by Letchian et al., I should know that the authors also found that mild and moderate forms of COVID-19 were more likely to demonstrate smell loss compared to the more severe forms in people who got hospitalized. However, the people who got more severe levels of smell loss, that mean those who had more profound losses of smell initially, were found to be less likely to recover. One of the probably more interesting as well as widespread discussions about COVID-19 smell loss has been parosmias, and that is a qualitative olfactory loss, and it's really associated often with unpleasant smells, and it's usually the perception that an unpleasant smell is there and it's altered. I have patients telling me that coffee and vanilla are two fragrances that normally they find very pleasant are all of a sudden smelling like urine or something really disturbing to them. And it's actually, as this study, which is actually not COVID-19 related, it's showing is that in this series of 56 patients with parosmias, the number of patients that really judge the VAS severity, which is a visual analog scale of how bad does it affect their lives from a 0 to 10. You have so many patients that are scoring the 8, 9, 10 range. And that is absolutely true in that patients, almost prefer to have no sense of smell than having this parosmia. And it's been typically presenting with our COVID-19 cohort in patients who have had smell loss for about 2 to 3 months, and they feel like they might even start to recover their sense of smell, and then they realize they're starting to feel some altered sense of smell. Unfortunately, the pathophysiology behind the parosmia phenomena is not really well understood, and it could be related to kind of miswiring of the olfactory neurons and regaining its connections to the olfactory bulb. And that's kind of some of the theories that's going on. But again, little is known about the actual pathophysiology. So speaking of pathophysiology, I'm kind of talking a little bit about what we know and don't know about COVID-19 related smell loss. I should start with saying that in general, causes of olfactory dysfunction from all etiologies, including other viruses, has not been well studied and not well known. And in fact, our stuff that we know about SARS-CoV-2 is really pushing these limits. And so, what we know, that a lot of people have heard of are the viral binding proteins of ACE2 and TMPRSS2, and that it's present in these respiratory epithelial cells as well as the olfactory epithelium. And so, as delineated by this virus icon here, we know that ACE2 as a virus binding receptor is very strong in succinacular cells, these horizontal and globose-basal cells, these stem cells in the olfactory epithelium. And they are not found in the actual peripheral neurons, which are the olfactory sensory neurons. So the theory is that the viruses potentially are directly attacking the supporting cells, which is the succinacular cells and the stem cells inside the olfactory epithelium of the nose. And the loss of the support cells or the disturbances of the support cells are either causing a indirect destruction of the olfactory sensory neurons or perhaps just turning off the receptor levels on the olfactory sensory neurons. But again, the etiology behind the smell, or but the pathophysiology behind the smell loss is just not well elucidated. I also wanted to take a moment to highlight this interesting study that was recently published by the Harvard group by Workman and colleagues, who have showed that essentially smaller aerosolized particles tend to travel to the olfactory epithelium and they bypass the rest of the nose or the respiratory epithelium. And this study kind of highlights a potential mechanistic, although maybe not biologic, way of explaining why sometimes in COVID-19 we're starting to see smell loss as the only symptom or as one of the more common symptoms and not nasal congestion, which is more common in other upper respiratory viruses. The theory is perhaps that with SARS-CoV-2, the particles of the virus are quite small and they're actually depositing straight into the olfactory epithelium or bypassing the respiratory epithelium to go into the lower airway rather than causing the nasal congestion that we're seeing with other viruses. So as I mentioned earlier, traditionally people are notoriously bad at recognizing their smell loss. And there's either a delayed recognition or sometimes often no recognition of smell loss. So really the what we consider quantified or semi-objective testing for smell loss is really helpful. And two of the best validated smell loss tests out there are the University of Pennsylvania Smell Identification Test, or the UPSIT, which is a 40-item self-administered scratch and sniff test booklet. And this really relies on smell identification, meaning can you recognize the scent? This is in contrast to the Sniff-N Sticks, which was developed in Germany by Professor Hummel, and that looks at three components. That's odor threshold, discrimination, and identification, or the TDI score, which people talk about, and that is summed up to be a total of 48 points. And so for COVID-19, a lot of times what I'm finding is that patients may have an improvement in the identification or recognition of the smell, but the threshold, meaning the strength of the smell or the intensity of it, needs to be at a much higher threshold to actually for them to detect it. I will mention that with COVID-19, the correlation between self-recognized smell loss and a tested dysfunction seems to be moderate to strong, as our team has published, and that is actually higher than the correlation that was studied in other etiologies of smell loss. The thing is that with COVID-19, the loss is so acute and so profound that I think people are better at recognizing that they've lost their sense of smell. I want to spend some time discussing potential therapeutics for olfactory dysfunction, particularly in the setting of COVID-19, because this is really of the greatest interest to us as clinicians. And unfortunately, as I tell on my patients, there's really no one magic cure. And if your patients are waking up the next day with complete recovery of smell loss, that probably was due to more of a spontaneous recovery than really any one therapy. So, this is a list of some of the treatments out there and potential treatments for smell loss. And I'm going to go through some of them today. I'm going to start with olfactory training because this really has the highest level of evidence, level 1A, supporting its use in patients with smell loss, really of all etiologies, as well as COVID-19 related smell loss. And the key thing is actually to do this for a prolonged period of time. So all the research has been shown that patients do well when they've used it for at least 3 to 6 months. And specifically in post-viral losses, olfactory training found an improvement in about 30 to 50% of patients, and I've seen as high as 60 some percent of patients. And that was defined as a clinically meaningful amount of improvement, which is greater than 6 points on a TDI scoring system using the sniff and sticks. So it's not a profound amount of improvement necessarily, but certainly one that is clinically meaningful, and this therapy is really easy to implement. And the idea of how to do it is to really practice smelling a variety of scents. Specifically, they recommend about 4 odors for about 20 seconds each time, twice a day, for at least, again, 3 to 6 month period. And really train yourself in remembering what that scent smelled like. So, for example, the classic 4 scents that people start recommending are rose, lemon, clove, and eucalyptus. And you want to think to yourself, I know what a rose smells like in my mind. I remember the scent. Today does not smell like that, but let me kind of recall in my mind what the scent of the rose is. And you're kind of strengthening perhaps the nerve connections and promoting regeneration of these olfactory signals to your brain. What one study found in this laryngoscope article is that if you can change up the scents every 12 weeks, the people who did that actually showed greater improvement than the ones that use the same 4 scents. So the most important thing is to pick odors of a variety of what we call a palette of odors. So they can't all be fruity or all floral. And I do definitely recommend some of these nonprofit groups out there that have great information about smell training. And in fact, this one group, absent.org, has what's called a sniff app, and they actually guide people to practice smell training and have a log of how you feel during that day. So it's a really great resource to have. The other therapeutics that are offered out there include high volume steroid irrigation. So this is very common in our ENT field, using off-label steroids such as budesonide or Pulmicort in our sinus rinses. And we know that high volume irrigations get up to the olfactory cleft in a way that normal nasal sprays do not. So while topical steroid nasal sprays like fluticasone and metazone are not really getting to the olfactory cleft, a sinus rinse bottle will. And so in this study that was done pre-COVID in a mixture of patients, including post-viral patients, the Stanford group found that 44% of patients improved on their UPSIT scores compared to 27% who just did smell training alone. And this was after 6 months of use with irrigations. And their improvement was a 5-point improvement on the UPSIT. So again, a clinically meaningful amount of improvement, but not a complete regeneration of smell. Other things that have been used and recently published specific to COVID-19 I want to highlight are 2 small randomized controlled trials that have come out of Europe. You can see here they're really only using a group of 9 patients, so we definitely need more literature on this. They use basically a combination of oral steroids with smell training compared to smell training alone. And especially the paper on the right, it's looking at sniff and sticks, which is that validated TDI scoring, and there was an improvement of 7.7 points versus 2.1 after 10 weeks of smell training with steroids. I should mention the dose of the steroids they used was a 10-day course of methylprednisolone of 32 milligrams daily. So that's equivalent to 40 milligrams of prednisone times 10 days. So a pretty high dose of steroids for 10 days. So again, we should counsel these patients that this is not without, as we know, a lot of the bad side effects of oral steroids and systemic steroids. But this is one of the studies that have been showing that in COVID-19 associated smell loss, that oral steroids does seem to have an improvement. One of the interesting studies that have come out recently from Professor Hummel's group over in Germany is how to treat parosmias. And, this is really great for so many of our patients that have developed COVID-19 associated parosmias. And this is using an intranasal sodium citrate. And the idea is that spray. So the idea is that sodium citrate is reducing the amount of free calcium in the olfactory epithelium, and it's thought to prevent the calcium-mediated feedback at the level of the receptors, so we can stimulate the receptors a little bit more. It did not do anything for smell loss. However, as you can see here in this study, in this figure, there was a significant improvement in both parosmias and phantasmias. And as I mentioned earlier, normal intranasal steroid sprays and any type of sprays really do not reach the olfactory cleft. Similarly, Dr. Hummel's group, the way they were able to reach the olfactory cleft using the sodium citrate sprays utilized a special delivery device. And in particular, they also recommend this head position called the Keitiki position. As you can see here, during one of their previous publications, this woman is laying on her side, and then she tilts her head at a certain angle 2 minutes through the sprayer drops. And on this diagram, you can see that when dyed, these drops do actually reach the olfactory cleft quite nicely. So it's really important to tell our patients when we're prescribing any type of sprays and drops that it's the head position and an optimal drug delivery device with maybe a long nozzle is more helpful than just the typical type of intranasal steroid spray canisters. In terms of the other therapies out there, I've put question marks next to them because the support for their use in COVID-19 has not been established. There are the topics of ongoing clinical trials around, and the support for their use has been in other etiologies prior to COVID-19. So for example, in omega-3, I was part of this trial that used omega-3 in skull-base patients, and these were patients who were undergoing endoscopic skull-base surgeries that were randomized to either being treated with omega-3 or no treatment after surgery, and assessing their olfactory outcomes. And the ones that were treated with omega-3 had improved olfactory outcomes post-operatively. Similarly, vitamin A and acupuncture are of interest, and they have been both used in post-infectious etiologies prior to COVID-19. The vitamin A study is a retrospective one looking at the benefit of these drops in post-infectious patients, and acupuncture as well, but both don't have strong enough data to really make a recommendation for at this point. So just to summarize, today we talked about smell loss and its associated taste loss as being the excellent predictor of COVID-19 infection. In fact, the strongest symptomatic predictor of an infection compared to all other symptoms, including fever. And really, roughly 75% of people are expected to spontaneously recover their sense of smell within 2 months of infection. And these numbers seem to be going higher, up to even a predicted 95% of recovery at 6 months. Parosmias are commonly found in COVID-19 associated smell loss, and these typically present at 2 to 3 months after initial smell loss. And above all, the best evidence therapy that we have for olfactory loss, it relies on smell training. And There are many other therapies that are being out there and being investigated, but by far, one of the things that we can do to recommend to patients is to start with smell loss as soon as possible. Thank you so much for listening, and happy to talk to you and take questions at the end.